Hello, my name is Christian Evans, and my presentation is based on the article Brain Functional Connectivity Patterns in Children and Adolescents with Gender Dysphoria. Sex atypical or not? To start, we should know, what is gender dysphoria? Gender dysphoria is a term that describes a sense of unease that a person may have because of a mismatch between their biological sex and their gender identity. This sense of unease or dissatisfaction may be so intense it can lead to depression and anxiety and have a harmful impact on daily life. Some key terms we should know are FTM, female to male, MTF, male to female, transgender, a person whose biological sex does not match their experienced gender, and cisgender, a person whose biological sex matches their experienced gender. Next, we have the article info with the publisher, authors, and journal, the Psychoneuroendocrinology Journal, with an impact factor of 4.98. Now, getting into the article itself, we'll start off with the abstract. The researchers in this article use different mode networks and pathways to determine if the functioning of a transgender brain is different from that of a cisgender brain. Some key terms are RSN, resting state network, GD, gender dysphoria, VN, visual network, SMN, sensory motor network, DMN, default mode network, FC, functional connectivity. Now for the introduction. Researchers use independent component analysis of various mode networks to study their hypothesis in this paper. Gender dysphoria onset can occur before, during, or after puberty, most often during puberty when secondary sex characteristics begin to show. An effective treatment for young transgender kids is the use of GnRHAs, or more commonly known as hormone blockers, around age 12 to stop further maturation of secondary sex characteristics. Symptoms of depression do tend to ease after this treatment, but there is typically no improvement in gender dysphoria until the use of cross-sex hormone therapy, which can be initiated around the age of 16. Although the number of neuroimaging studies in people diagnosed with GD is increasing, there is still little known about the neurobiology of GD. The most common hypothesis is that people with GD have experienced sex atypical differentiation of the brain during fetal development. Recently, several resting state functional magnetic resonance imaging studies, or fMRI studies, which examined functionally integrated relationships among spatially distributed brain regions, also called functional connectivity, or FC, suggested some new explanations regarding the neurobiology of GD in adults. While resting state fMRI studies in adults with GD have received increasing attention, fMRI studies in children with GD are rare, and resulting state studies that highlight the neurodevelopmental aspects of GD are currently lacking. Therefore, in the current cross-sectional study, they examined the FC patterns in youth with GD and compared these patterns to those of age-matched cisgender boys and girls. Their hypothesis was that prepubertal and adolescent boys and girls with GD showed GD-specific FC patterns, and that cisgender sex differences in FC patterns would be more prominent or only apparent in the adolescent groups. Next, we're on to methods and materials. In this cross-sectional study, which was approved by the local ethical committee, they included prepubertal children and adolescents diagnosed with GD according to the fourth revised edition of the Diagnostic and Statistical Manual of Mental Disorders, and age-matched cisgender boys and girls. A written informed consent was obtained from all participants and their legal guardians. There were 31 children with GD, 18 MTFs, 13 FTMs, and 40 adolescents with GD, 19 MTFs and 21 FTMs, and 39 cisgender children, 21 boys, 18 girls, and 41 cisgender adolescents, 20 boys, 21 girls. Participants with GD were recruited at the Center of Expertise on GD of the VU University Medical Center in Amsterdam. Cisgender participants were recruited at several primary schools in the Netherlands and by inviting friends of the participants with GD. In all participants except the cisgender adolescent controls, the prepubertal stage was determined by a pediatric endocrinologist according to the Tanner classification. In the cisgender adolescents, the pubertal stage was assessed by the means of the 5-point Tanner Maturation Scale self-report questionnaire, which correlates highly with physician assessment. The prepubertal children with GD received psychological counseling and no hormone treatment at the time of inclusion. The adolescents with GD were included while receiving GnRH. Of the initial 81 included prepubertal children, 11 were excluded from the analysis, 9 because of excessive head motions during scanning, 1 because of technical errors during data collection, and 1 because the child no longer fulfilled criteria for a GD diagnosis at the time of scanning. Of the additional 83 included adolescents, 2 were excluded from analysis, 1 because of a cerebral venous anomaly, and 1 because of excessive head motions. Urinary estradiol concentration was measured by a competitive immunoassay. Estradiol levels were corrected for creatinine concentration, which was measured by the Joffe method. Salivary free testosterone levels were determined with an isotope dilution liquid chromatography tandem mass spectrometry method. Scans were performed on a whole body 3T MR scanner. Gradient echo planar imaging sequence was used to obtain the T2 weighted resting state image. Statistical parametric mapping was used. The anatomical images were segmented into gray and white matter images, which were then used to create age group specific templates. The data of the two cohorts were analyzed separately. As stated before, this was a cross-sectional study. The individual network images of prepubertal children and adolescents were entered into separate one-way analyses of variance or ANOVA. Statistical tests performed were considered to be significant at a p-value under 0.05. We have now reached the results and discussion. Going into the results and sample characteristics. Reported sexual orientation varied in the prepubertal group. In contrast to the prepubertal children, sexual orientation in the adolescents was more consistent. Most trans girls and all adolescent cisgender girls were androphilic. All trans girls and adolescent cisgender boys reported to be gynophilic. Going back to the RSNs, in the prepubertal children, they identified 3 VNs, 2 SMNs, and 1 coherent SN. The DMN was fragmented into an anterior, posterior, and lateral network. In the adolescents, they identified 2 VNs, 2 SMNs, and 1 coherent SN. The DMN was fragmented into 4 separate networks. Going back into FC differences. Among the prepubertal children, FC in all networks was similar across groups. Among the adolescents, 2 group differences in FC were found. Adding RMS of translational head movement and age as covariates did not significantly change these results. Post hoc analysis method is shown in Figure 3. Trans girls showed stronger FC in the right cerebellar hemisphere compared with all other groups. Within SM2, cisgender girls showed stronger FC in the SMA than cisgender boys and trans boys. Furthermore, in the same brain area, FC was stronger in trans girls than in cisgender boys. FC in the right posterior cingulum with the posterior DMN was stronger in cisgender boys than in cisgender girls, and trans boys. Effects of endogenous sex hormones and duration of GnRHA treatment on FC. They used testosterone in adolescent cisgender boys, estradiol in adolescent cisgender girls, and weeks of GnRHA use in both trans girls and trans boys as independent variables, and the mean beta values of the significant clusters as dependent variables. There was no significant relationship found. Going back to the discussion, in adolescent trans girls, a singular GD-specific FC pattern was found. In addition, sex-atypical FC patterns were observed in both adolescent trans girls and trans boys. In contrast, in prepubertal children diagnosed with GD, they did not find any FC differences among groups. Identification of multiple VNs and SMNs is in line with studies performed in adults. While in adults, the DMN is often reported as a single coherent network. In children, fragmentation of the DMN is common. The researchers speculate that prolonged distress, such as negative self perception and psychosocial stress due to GD, may lead to alterations of FC between brain regions involved in emotional processing. Adult trans men and trans women showed an FC profile different from that of their sex assigned at birth. The adolescent trans boys showed a sex typical female FC pattern within the posterior DMN, whereas the adolescent trans girls had an FC that was comparable to their experienced gender, thus sex atypical female. Yet other studies have found that trans boys have a different FC than all the other groups, displaying a GD specific pattern. They did not find any evidence for sex typical or atypical or GD specific FC patterns within the SN of adolescent participants. FC patterns in prepubertal children. In pubertal children, they did not find group differences in any of the RSNs tested. This may indicate that brain maturation is important for the development of sex differences in FC patterns. It has been shown that only about 16% of the childhood GD cases will eventually lead to adult GD. That leads into the conclusion. The data suggests that transgender adolescents show GD-specific as well as sex-atypical FC patterns, possibly subjective experiences related to GD as well as an atypical sexual differentiation of the brain are associated with these FC alterations in adolescents with GD. Now we will be moving on to the limitations. Firstly, the sample sizes, especially of the prepubertal girls with GD, were only modest, which limits the generalizability of the findings. Secondly, the classification of sexual orientation must be interpreted cautiously because of the young age of the participants. While previous studies suggest that GnRHA administration does not induce sex atypical brain activation patterns in gender dysphoric adolescents, and this articles did not show any association between endogenous circulating sex steroids or duration of GnRHA treatment and FC, you can't completely rule out that the GnRHA treatment in adolescents with GD might have affected the results. Withholding or delaying puberty suppression treatment, which prevents further sexual maturation and leads to relief of distress, um, due to participation in scientific research, was considered undesirable or even unethical and could not be tested. Symptoms of depression are known to affect brain functioning/connectivity. This later finding suggests that distress resulting from withholding treatment would have caused changes in brain function and connectivity and would have therefore messed up the results. These next two sections are going to into the future directions of the study and how it may affect other studies. So why is this so important? It affects the way the world views trans people. People tend to be more willing to believe something exists and treat those people with respect when there is scientific evidence backing it. It provides a clear look into why this phenomena happens. Providing this clear look into why some people identify differently than their assigned gender shows that they are truly born this way and it's all a part of nature's design. It opens new gateways for more research. It also opens the floodgates to more longitudinal studies on things such as hormone therapy effects, effects of long-term hormone blockers, different surgical techniques for trans people, etc. How could this be applied to other psychology? Further research is needed to examine whether sex-typical or atypical FC patterns within the posterior DMN in individuals with GD could be translated to behavioral differences in self-referential processing or cognitive abilities, therefore proving a difference in the cisgender brain and the brain of a transgender individual. Developmental changes in FC, influenced by age and puberty, can only be studied by means of longitudinal designs. This means there is a long way to go before we can have better answers on these types of research questions. Now going into the link with autism. There have been various studies that hypothesize a link between gender dysphoria and autism. While not all transgender people have autism, there is a higher percentage in the cisgender population. Discovering how the brain develops and becomes a transgender person could also lead to further research in the link to autism. When discussing depression, while being transgender is not directly linked with depression, it may be useful to take into account when studying depression. Many, pe- that, many people that are transgender also have depression due to general dysphoria in oneself. We might be able to get a framework on how depression works in the brain through the study of transgender people and how, on most occasions, their depression is cured through hormone therapy. Lastly, we can translate the studies done on brain development to people who do not identify as male or female. In this context, they might relay a completely different FC from every other group, or even display individual FCs depending on the person. Overall, as clinicians and researchers and psychologists, if we could learn more about how the brain works in general and how brain disorders manifest themselves, we can work to help individuals who are affected and get them to a place in life where they would like to be. Thank you.